to cover some of the bases and drill down on some of the details that Dr. Warner, Dr. Wallen, and Dr. Olberg had covered this morning. And of course, in this case, with cardiac disease, what better to do than to get a cardiologist here?
Thank you very much for the kind words, David. I'd like to thank the organizing committee for inviting me to speak on carcinoid heart disease. It's a great honor for me. And I was just flipping through the program, and I was absolutely thrilled to see that one of the speakers is from Pune, India. And the reason that it's a big thing for me is that my mom's from Pune. She went to medical school from Pune, and I just met the gentleman in the coffee break, and he lives in the same area that my mom grew up in and that my aunt is living in. So I'm just absolutely honored to be here. I'd like to congratulate Maureen and Robert Reed because they've done an absolutely splendid job putting this program together. And I'm a cardiologist. I feel like a foreigner. This is an oncology program. But if you guys are doing this, boy, cardiology is really behind the eight ball. So I don't have the... So I'm talking about carcinoid heart disease. Carcinoid tumors are very rare. And actually getting carcinoid-induced heart disease is supposed to be quite common. In the literature from the 80s and 90s, approximately 60 to 70% of people are predicted to get carcinoid heart disease. Well, it seems to be a big problem because people die of this. The most common cause of death in people who have carcinoid disease is apparently heart failure due to right-sided heart failure. The first case, first published in 1954, was actually somebody who was hypoxic, had severe tricuspid regurgitation, pulmonary stenosis, and a patent foraminovalle. Also had some left-sided lesions. In the 1990s, more elegant studies were done on carcinoid heart disease, mainly because of the advent of echocardiography. And what we have found is that we can now diagnose heart disease much earlier because of echocardiography. Now, the belief is that the vasoactive substances released by the tumors attack the right heart. Initially, what happens is when they're released from the midgut, they get deactivated in the liver. But as you get hepatic metastasis, the tumors secrete directly into the IVC, into the hepatic veins, which of course dump directly into the right heart. Usually what we see is specific findings on both the tricuspid and pulmonic valves. And what we find is a plaque-like substance. It's a glistening white substance that is very, very pathognomonic for carcinoid-induced heart disease. Pulmonary valve involved with a combination of pulmonary stenosis, pulmonary regurgitation. The tricuspid valve, universally involved, also gets some involvement of the pulmonary outflow tract, causing subvalvular or supravalvular pulmonary stenosis. Now, you can get left-sided involvement. Now, to get left-sided involvement, you have to get the tumor substance into the left side of the heart. The tumor vasoactive substances are believed to be deactivated in the pulmonary vasculature. So somehow, those substances have to bypass that area. So one of three things happens. Number one, you can have bronchial carcinoid, which dumps directly into the left side of the heart. Hence, you get left-sided heart involvement. Second, you can get a shunt at the atrial level, classically a patent foraminovalle, and 25% of the population walks around with a patent foraminovalle. And lastly, if you get overwhelming levels of serotonin, they can overwhelm the pulmonary circulation and you can get spillage into the left side of the heart. Now, the pathogenesis. Plaque-like structure, fibrous deposition on normal cardiac architecture. So, firstly, you do not have to have abnormal valves to start off with to get carcinoid-induced heart disease. You basically can have normal valves. What's causing it? Well, we don't know. But what we do know is that serotonin probably is a culprit or is a major culprit. We know that high levels of serotonin occur in these patients. Higher levels of serotonin occur in patients who develop carcinoid-induced heart disease than those who do not. Now, about 10, 12 years ago, or actually 15 years ago, anorectic or diet drugs were being pushed on the market. And then in North Dakota, a very astute physician said, my patients are developing heart failure and something's wrong with the valves. And it led to a landmark paper in the New England Journal of Medicine by Dr. Connolly, which showed that if you were taking these diet-induced or diet pills, fenfluramine, phentermine, you were getting lesions on the left side of the heart that were exactly the same morphology as what we were seeing in carcinoid heart disease. These medications are serotonin analogs. As well, people who are on migraine medications that have ergotamine or methotrexate also develop lesions that are very similar to carcinoid heart disease. And so we know that serotonin plays a very, very important role. Animal models, I must also add, have been developed that support this hypothesis. Well, how do you make the diagnosis? Well, it's echocardiography. And essentially, it's very, very classic. You see thickening initially of the tricuspid and pulmonic valves. It then goes even further. The valves become fixed, retracted, decreased mobility of the leaflets. If you can imagine, if the leaflets can't move, the valve leaks. And universally, you see tricuspid regurgitation. And I tell my residents that quite often you can't even see the tricuspid regurgitation because it's so severe, and you just don't see any color flow turbulence because there's such severe tricuspid regurgitation. Tricuspid valve, you get a combination of pulmonary valve, you get a combination of pulmonary regurgitation and pulmonary stenosis. The TR on the slide stands for tricuspid regurgitation. The TS stands for tricuspid stenosis. PR, pulmonary regurgitation. PS, pulmonary stenosis. So what? Well, the problem is that with time, a combination of a leaky and stenotic valve, especially a combination of tricuspid regurgitation, where the valve is leaking between where the blood's leaking between the atria and the ventricle, and pulmonary stenosis, where the blood can't get across the ventricle, leads to right heart dilatation. Eventually, with right heart dilatation, you get hypokinesis and eventually right heart failure. Symptoms initially are very nonspecific, fatigue, then you start to see backload of volume into the venous circulation, edema, ascites, and eventually cardiac cachexia. There is a huge difference between the right ventricle and the left ventricle. The right ventricle is the subpulmonic pump, meaning that it just pumps blood from the right ventricle into the pulmonary circulation. The pulmonary circulation is a low-pressure sink, a low-pressure vasculature. So really, the right ventricle is not designed to deal with lots of volumes, and it's not designed to deal with high pressures. The left ventricle pumps, of course, into the systemic circulation and is a pump that is designed to basically withstand high pressures. Therefore, there is a huge difference between treatment for the right ventricle and the left ventricle. In terms of the left ventricle, we have literally about 1 million patients randomized to trials looking at heart failure studies. And we have good evidence that we can actually reverse some heart failure in people where the left ventricle has been affected. ACE inhibitors, now angiotensin receptor blockers, beta blockers, aldactone, and surgical procedures such as the Dora procedure. Well, what about the poor right ventricle? Well, there's really only one thing that works, and that's palliation in the form of diuretics. It just reduces volume. Digoxin might work. We don't know. The Bible of Cardiology is a textbook called Brunwald's Textbook of Cardiology, and they highly recommend not using digoxin in people who have right heart failure. Nobody really knows. Dr. Brunwald said that, so basically take it as gospel truth. I do adult congenital heart disease, and in adult congenital heart disease, we have people whose right ventricle fails, and these are people who have things like truncus arteriosus or tetralogy of Fallot. We don't think that ACE inhibitors work the same way as they do in the left ventricle in these patients, but we are designing trials looking to see if ACE inhibitors do improve right ventricular function in these patients. Surgery, we do in cardiology for one of two reasons: to either make patients feel better, so symptomatic improvement, or to make people live longer. And in the 1980s, surgery was done for right heart failure in these patients, and the mortality rate was extremely high. And the most common cause of problems postoperatively was right ventricular failure and postoperative bleeding. So that's kind of the background of what's going on, and I'd like to quickly talk about 2008. So what is the prognosis of these patients? Who develops carcinoid heart disease? What we do know is that most deaths in patients who have carcinoid heart disease are due to heart failure. We also know that patients who develop carcinoid heart disease have higher levels of serotonin. Well, I'd like to start off with the Mayo Clinic group again. Elegant paper, New England Journal, 2003. A total of 103 patients, retrospective. And most of our data in carcinoid heart disease is retrospective data. 32 of these patients were referred for surgery at the Mayo Clinic. 71 they were actually followed at the Mayo Clinic. And they found two very important points. Firstly, higher levels of serotonin correlated with increased severity of carcinoid heart disease and also with the progression of carcinoid heart disease. So that was the first time that really we had such a good trial that delineated an increase in serotonin level, severity, and progression of carcinoid heart disease. But what other groups had found in much smaller numbers, the Mayo Clinic also found, and that is these patients, when they received serotonin analogs or got hepatic embolization to reduce tumor load and hence also decrease serotonin levels, made no difference. These people progressed in their heart disease. 2 years later, the same group published another paper, again retrospectively in Circulation, looking at 200 patients who had carcinoid heart disease. And they basically broke them down into three cohorts. The first cohort they looked at were people who were enrolled in their institute from 1981 to the summer of 1989. The second cohort from the summer of 89 to the spring of 95. And then the third cohort from the spring of 95 to the end of 2000. Their end point was looking at all-cause mortality. And what they found was that the median survival improved dramatically from 1.5 years all the way up to 4.4 years. So what's the cause of this? Well, multivariate analysis found that the only predictor was cardiac surgery, and that if these patients had cardiac surgery, they survive longer. Remember, most of these patients die of right heart failure. So what they found is that if you can intervene on these patients before they die of right heart failure, you could potentially make them live longer and potentially also make them feel better. Predictors of a poor outcome, not surprising. New York Heart Association class. So if you were more symptomatic, less likely that you were going to do better. And we know that from cardiology in our heart failure patients. And as well, the bigger the right ventricle, the worse the outcome. Their criteria for doing surgery was much different in the Mayo Clinic than what we generally think of in cardiology. One was for heart failure symptoms, which we do, but they did not do surgery to improve survival, because at that time they were thinking that wasn't the case. The other reason they did surgery was before basically major hepatic surgery for resection of metastasis. So I'd like to end off with two papers that have come out in 2008, which I hope tie things together. The first is from the Royal Free Hospital in London, UK. And basically what they wanted to do was try to establish the prevalence of carcinoid heart disease in the year 2008. And what they did is they performed transthoracic echoes in 150 consecutive patients. Now remember, the prevalence of carcinoid heart disease was thought to be around 60 to 70%. And they were kind of surprised it was closer to 20%. And in our institution, I don't have the numbers because we don't have a database on this, but my feeling is we're very, very close to that number. Also, these people had very minimal symptoms. New York Cardiac Association Class 1 or 2, which means no symptoms or minimal symptoms, versus Class 3 or 4, which means moderate to severe symptoms. What they also found was that 40% of these patients had no clinical evidence of heart disease, meaning that as a cardiologist, I put a stethoscope on their chest, I can't hear the murmur. And I'm not surprised. Doing adult congenital, murmurs of PR and PS are extremely hard to hear, and when you get severe tricuspid regurgitation, you essentially can't hear it. The other finding that was extremely important is that there were significantly higher levels of 5-HIAA in patients who had cardiac disease than those who had no echo evidence of not having any disease in the heart. So why the decrease in prevalence? Well, I don't think we know for sure, but perhaps it's due to the earlier initiation of somatostatin analogs. That potentially is one possibility. Could chemotherapy have a role? I don't know. I'm not an oncologist. But there are two important points I want to basically drum in. One is, as a cardiologist, I need to see these patients well before they develop symptoms of heart failure. And number two, a significant proportion, 40%, could not be clinically diagnosed as having heart disease, but yet echocardiographically they did. Hence the importance of a good quality echo to make the diagnosis. The same group published a paper 16 days ago or 15 days ago, and they screened 200 consecutive patients with transthoracic echo. Now these patients again were all comers, and they also measured something called brain natriuretic peptide. Now brain natriuretic peptide has been around for a while. We can't use it in Canada because the government doesn't pay for it, but it's used throughout the world as a marker of patients who are in heart failure. And so in the States, for example, if somebody comes into the emergency room, they have COPD, they're short of breath, you take a look at the chest x-ray, you can't tell what's going on, you listen to the lungs, you can't hear anything, you aren't too sure if it's heart failure or COPD exacerbation, they do a BNP level. If the BNP level is high, it's most likely due to heart failure. So all these patients got a BNP level. Well, a couple things. Number one, same kind of incidence of the prevalence of heart disease, 20%. But the major finding was that the BNP was significantly elevated in those patients who had developed carcinoid heart disease. Over 1,000 picograms per milliliter versus 100 picograms per milliliter for those that had or had not developed echocardiographic evidence of carcinoid heart disease. Also, the BNP level correlated with the severity of the lesions and the severity of the symptoms. As a screening tool, and this is only a screening tool so far, this gives us a very, very high negative predictive value. So I'd like to conclude by hopefully putting everything together. Number one, it looks like the prevalence of carcinoid heart disease seems to have fallen dramatically. We're going to see over the next 4 or 5 years whether other centers replicate the findings from London and elsewhere. Perhaps, and this again is a perhaps, the early institution of somatostatin analogs is the cause of the decrease in the prevalence of carcinoid heart disease. BNP is an important screening tool. Echocardiography is also an important screening tool, but the value of echocardiography is the maintenance and follow-up of these patients who develop heart disease. And lastly, cardiac surgery seems to be very good in the left ventricular side in terms of reducing morbidity and mortality. For the right ventricle, the same thing holds true from what we can see in the literature. However, these people need to be intervened on before the right ventricle starts to fail. And I'd like to thank you for your time.
Thank you, Dr. Gibbs. And think Dr. Diaz does bring up some very important points and very good reminders to us as practitioners as well as those afflicted with carcinoid neuroendocrine that truly if you don't suspect it, you can't detect it. And the incidence of carcinoid-induced and neuroendocrine-induced cardiac disease may be falling, but it still behooves upon us as practitioners to be able to identify and screen for that as a potential complication of the disease process.